Hello and welcome to everyone. This is a February NCAPS webinar on preventing out-of-home placements for children through person-centered wraparound. We are glad that you all can join us this afternoon or morning, depending on where you are in the country. I will begin with a quick visual description of myself. My name is Bevan Croft. I'm a white woman. I have blonde hair with bangs, and I'm in my home office with a number of different plants behind me. I'm wearing a black top. And I co-direct the National Center on Advancing Person-Centered Practices and Systems administered by the Human Services Research Institute. And we're pleased to bring you webinars on various topics related to person-centered practices in human service systems. Next slide, please, Sashka. So NCAPS is an initiative that's funded by the Administration for Community Living and the Centers for Medicare and Medicaid Services. It is co-directed by Sashka, who is running slides and some support along with some of our other colleagues. Next slide, please. For those of you who are unfamiliar with NCAPS, our broad goal is to make person-centered principles not just an aspiration, but a reality in people's lives. And we do that through technical assistance and learning opportunities and resources that you can check out on our website. We've been around for 6 years now and have quite the resource library to share with you. Next slide. A few webinar logistics before we get started. This is a webinar format, so you're all muted, but you're welcome to interact with us, and some of you already are on chat. It's always great to have a conversation on chat throughout the webinar. You can use chat to ask questions of the panelists as well, or to interact with the community here. And if you'd like your chat to be seen by everyone on the webinar, be sure you select everyone in the drop-down box above where you type in your comments. We have live captioning available today in English and also live interpretation in Spanish. You can access the English captions by clicking the CC button at the bottom of your Zoom screen. And the Spanish interpretation is available by clicking the interpretation button. It's a world icon. And once you're in the Spanish channel, you'll want to silence the original audio. And we have just a couple of polls at the beginning and the end of this webinar. So please be prepared to interact then. And actually, I think we have a poll right now coming up. Oh, no, one more bit of information. If you do have questions for us or would like to get in touch, you can email us at ncaps.hsri.org. But we're not monitoring that during the webinar. Please use chat to communicate with us during the webinar. And we don't provide CEUs, but you will get a confirmation of attendance after the close of the webinar. And finally, all of our materials will be up on the website within a few weeks. The recording of this webinar, the slides, and a summary of the webinar as well. So please do check that out, and remember that recordings of all of our past webinars are also available on our website. Okay, let's see who's here this afternoon. Please, in this poll, select all that apply in terms of the roles in which you self-identify, and recognizing that people may have multiple different identities or roles, and also that there may be some roles that are not reflected here. You're also welcome to put a role that you have into chat so we can see who's here. So I'll give folks a few moments to do that. And it's nice to see everyone saying hello in chat as well. It's cool to see how people are tuning in from all across the country. Give folks a few more seconds to reply. Okay, so it looks like about half of us here today are government employees. Half of us are social workers, counselors, or care managers. We have a good number of advocates and self-advocates, some providers, some researchers, a few peer specialists, wonderful, and folks with their own direct lived experience of navigating systems as well. So thank you to all. We are so glad that you're here. I'm pleased to introduce you to our two panelists next. We will hear from Tony Donnelly and Kim Estep. Kim Estep is faculty and director for system design and implementation strategies at Innovations Institute at the University of Connecticut, or UConn. She is also the director for the National Wraparound Implementation Center. Kim is responsible for supporting and managing state, organization, and provider efforts around systems reform and wraparound implementation to improve quality of existing practices across the nation. And we will also hear from Tony Donnelly, who joined the Innovations Institute as a national trainer and coach for peer parent support and wraparound. While Tony's expertise spans system and provider levels, her approach to technical assistance is informed by her most significant role as a parent raising 3 sons with emotional and behavioral health needs. Tony applies her non-adversarial advocacy as a parent on behalf of her children, coupled with her expertise navigating child-serving systems to support and inform systems transformation. So we're excited to have you both here, Kim and Tony, and I will turn things over to you.
Great, thank you so much. I should share my screen now, right? I'm not like we do this for a living or anything. Tony, I'm gonna share my screen, and if you want to go ahead and introduce yourself, then I can introduce myself and kick us off, if that's all right with you.
Yes, that's fine. Good afternoon, everyone. My name is Tony Donnelly. I have short gray hair with bangs. That doesn't necessarily mean I'm old, but I'm also wearing blue and white, and my background is a blue Yukon background with Jonathan Husky.
Thanks, Tony. So I am Kim Estep. I am a white woman with long blonde hair. I have on a coral top, and I am in my home office. I have some beautiful trees and a picture behind me that folks say that, is really color coordinated with the top that I have on today. So also glasses. So it is great to be here today, and thank you all so much. We are going to talk a little bit about wraparound, and I know wraparound has been around for a really long time, and so we are going to walk through a little bit of how we got here today, because I do think that there's been quite an evolution around wraparound. We're also going to define wraparound and talk about what it is and what it isn't, and how wraparound sits across levels in a system, meaning that it, what does it look like from a system perspective, from a provider and a local perspective, as well as, of course, at the family level. And we know more now than we ever have before. We've learned a lot over the years. We also know, though, that change can be hard. And so when we think about wrap around and we think about navigating systems, that it can be really confusing. I think it's confusing sometimes for us that work in it, right? I think Tony can agree with me. We work in a lot of states across the country and we get confused. So I can't imagine being, a family in a system trying to get help for, our children, our family members and so on. But it's really exciting too. Change can be great. And so I want to walk through some of that today. And I want to start with, ironically, I want to talk a little bit about care coordination, because I think that the intensity of care coordination efforts is really important to set the stage around what good modern systems should include. And it should include a continuum of intensity of support. And thinking about that graphic on the screen at the very tippity top, well, it's an upside down pyramid. So, it is the top, but it's the biggest portion of the upside down triangle. That this is about universal health promotion that includes healthcare and screenings, typically performed by primary care providers, pediatricians, possibly schools, if there's school-based mental health or IEP needs or individualized education plans and so on. And then as we move through the continuum around care coordination, that next step involves those moments when families say, uh-oh, I need help. Like, I've tried calling my mom, I've tried calling my dad, I've called my best friend, I've called my sister, my neighbor, everybody that I know to talk to. And I need a little more. Like, I'm not really getting the information that I need. And so they're reaching out for the first time outside their family, outside their natural network, and they're looking for help. This could be a family support organization. It could be that they're reaching out intentionally to the school in a more formal way, like outside just the typical teachers. It could be some sort of navigation line in the state that they're reaching out to. And so that is a needed tier. If we think about, those care coordination efforts, that is a needed tier in a system for how do we find things that we need? How do we locate the stuff that we're looking for that we think may be helpful? And then as we start to move further in the triangle, there's a moderate level of need for care coordination that could involve multiple services and supports. It could involve maybe multiple children in a family that need help. There's also probably high caregiver stress or strain at this tier. But this is when they're reaching out. Families are typically reaching out to systems. They're reaching out to community mental health centers or certified community behavioral health centers. I don't know if you're familiar with that CCBHC effort, but that is growing around the country. And that I have to put this plug in for those listening, that wraparound light is not a thing, okay? And if you take nothing else away from this, wraparound light is not a thing. We don't get to pick it apart. We don't get to decide what works or what doesn't. In that moderate level need, we need to do something else, right? So I want to keep, that's not what we're here to talk about today, but if you have questions or want more information, please reach out. And Tony and I are very happy to talk about that. And then today we're really talking about those families with young people, children with significant challenges, complex behavioral health needs, high caregiver stress and strain, multiple needs that are probably not met by a single system or a single service. And it works best, we're going to talk about this later, it does work best with dedicated organizations, either through a care management entity or a care coordination organization that is dedicated specifically to those care coordination efforts. And that's really, where we are today. And I do want to talk a little bit about how did we get here? How did this thing called wraparound come to be? So in the 70s and 80s, Wraparound emerged from efforts to do whatever it took to get young people, children back in their homes and in their communities with their families. And it literally was, whatever you need, we're going to give it to you. Whatever we need to do, we're going to do it. And that was how it started. And it started in different pockets around the country. And so as you can imagine, with a do whatever it takes approach, that would lead to a lot of variability across the country. It would lead to a lot of different understandings about what wraparound is, what does it mean to actually practice wraparound, and all of those things. It also, at this point in time, and even into the 90s, it was primarily grant funded. So a lot of system of care dollars, if you're familiar with that. And there were concerns that wraparound really wasn't defined well. And so that led to the original creation of the 10 values and principles, which Tony will talk about a little bit later and show you what those are. But even in that definition, or the values and principles being laid out, it was still a little bit left, well, it wasn't a little bit, it was kind of a lot left open to the care coordinator around what does that actually mean. So similar to do whatever it takes, if we're talking about an individualized approach or person-centered planning approach, that might mean something different to everyone. And so again, it leads to a lack of practice standardization and what that actually looks like on the ground and across the country. And so states begin to think about, ooh, what's going to happen as we start trying to figure out how do we pay for this with Medicaid dollars or a different financing stream. And so there was an expert convening that happened again, and there were, activities and roles defined, and really trying to support states who were moving into that Medicaid space, and really trying to formalize and expand wraparound, into like large statewide efforts. And at this point, the National Wraparound Initiative was born, and Innovations was a part of that all those years ago. A little tidbit, and now it'll be memorialized wherever this video sits. But Eric Bruns, who, if you're not familiar, he is one of the co-directors for the National Wraparound Initiative. He's been part of Wraparound for a really long time. And he actually started the Innovations Institute all those years, long ago, and then left. Like, he started it and left and went off to the University of Washington. And we still partner with him today. He is a part of the National Wraparound Implementation Center with us, but that's just a fun tidbit. If it's ever on a wraparound trivia question, you all will have a leg up with that. But in 2012, we still had a need to formalize, how does wraparound get disseminated and installed for states, and how do we really clearly define what this work looks like when we go to scale, and it's being increasingly funded through a Medicaid arrangement. And so we needed to make sure that we had clear practice expectations, training, access to expert coaching, and so on. And so that is, a huge, a big evolution. And that's not where it ends, because as wraparound was increasingly being implemented through Medicaid, it means that systems have to shift. And so we have a brief animation that we want to show you so that you can see and hear about a little bit of that evolution from that system perspective.
The wraparound movement began in the 1980s in response to the lack of effective community options for providing intensive supports to youth with complex behavioral health needs and their families. Over time, wraparound has become a well-defined and research-based care coordination practice model. Wraparound also serves as a system intervention that supports behavioral health reform at the state, local, and program levels. At the state level, Wraparound works to hold states accountable for ensuring that an array of evidence-based clinical services and non-traditional supports are in place. Wraparound initiatives also promote workforce development, access to peer supports, quality assurance, and outcomes monitoring. All these activities together aim to ensure that costs are reduced and also that youth and families have access to high-quality community-based care that meets their individualized needs. At the local or program level, Wraparound requires that providers collaborate to serve a population of youth whose needs exceed the resources and the expertise of any one organization or child-serving system. To do this, providers must extend their perspective beyond the walls of their own organizations and work together to do whatever it takes to ensure youth with behavioral health challenges and their families live and thrive in their homes, communities, and schools. At the youth and family level, Wraparound is unlike traditional services in that it is a team-based care planning process in which formal and informal supports partner authentically to address the root causes of the challenges faced by families. The Wraparound Care Coordinator works with the young person and their family to convene a team of friends, neighbors, and community members, as well as service providers and other supports, to develop a comprehensive, individualized, and creative plan of care. This is not your traditional plan of care. The care coordinator works to support system partners to be flexible in expectations and pushes service providers beyond their traditional roles. Informal supports take on key strategies in the plan of care, further supporting the family in meaningful and enduring ways. The Wraparound team then collaborates to implement the plan, monitor progress, and revise as necessary. There is now strong evidence that when Wraparound is done well, or with fidelity, young people are more likely to stay in their communities and to experience improved mental health and better functioning across life domains. Extensive evaluation data also now show that all of this effort typically saves money by minimizing the time young people spend in out-of-home facilities like residential treatment centers or hospitals. Wraparound is growing in its adoption nationally, but states and organizations still struggle in moving beyond a value base and toward high-quality practices and care planning. The National Wraparound Initiative and the National Wraparound Implementation Center have gathered many resources and tools to ensure that this work is done well across all levels of effort, so that wraparound programs will achieve the positive outcomes that have been demonstrated in states across the country. We encourage you to look at these materials or to visit our websites to learn more.
Great. And now I think I'm going to turn it over to Tony, who is going to tell us a little bit more about wraparound across those levels that you just heard about.
Thanks, Kim. One of the things that we've come to recognize over the course of wraparound's evolution is that wraparound is not just a practice model or a service. Wraparound is a system intervention that requires significant reconfiguration, meaning that systems will have to transform some of the things that they do for wraparound to be implemented successfully and to work well for families. This is because most systems are not set up in a way that supports wraparound. The experience of many young people and families is that they had to fail up the system to get what they need. And in some cases, youth and families may even end up at the very top of the system of care or in residential or some other out-of-home placement before other levels at a lower level have been tried. And this is often also included wraparound. So what is wraparound? At the organization and provider level, wraparound is different from traditional outpatient services, including case management. Wraparound really requires that providers look outside of their own organization and explore all possible options or choices that are available, including those informal and community options to meeting the family's identified needs. The one thing I'd like to stress here is that no one organization can do wraparound on their own. It really requires collaboration with other community and system stakeholders. It requires organizations to reconfigure their policies, procedures, and other expectations to implement and support wraparound implementation effectively, and to also ensure that families experience something different than they have in the past. So wraparound is a community-based effort that brings relevant providers, community members, and informal supports to develop an individualized plan that is based on the youth and families' unique identified needs. Wraparound is not a cookie cutter list of services. So why is wraparound important? Wraparound is based upon accessing community resources rather than system resources. So at the family level, we need to ensure that wraparound is implemented in a way that ensures that young people and families have robust options to choose from, and that they're able to choose options that they believe will be a good fit for their family. This can sometimes be a challenge, as systems that have oversight, such as Medicaid or managed care entities, because they may be accustomed to making decisions without families around what is needed or what's appropriate, and then they hand these to the families. So in wraparound, the care coordinator serves as a guide who oversees the team process and takes the lead on cross-system collaboration, pooled resources, collective mandates, family voice and choice, and consensus building. Relationships are at the heart of healing. Wraparound facilitates healing by creating an infrastructure for forming and sustaining circles of support for people and families with complex needs. So as Kim mentioned before, all of the work that we do in wraparound is predicated on these 10 values and principles. These 10 principles set the foundation for wraparound to be implemented with fidelity. These principles are what makes wraparound different from other care coordination practices. Each of these principles that you see on the screen need to be operationalized throughout all 4 phases of the wraparound process. Additionally, it is important to keep in mind that each of these principles carry equal weight and value. There is no principle that is greater than another. So let's just highlight a few. We'll highlight the first one, family voice and choice. So in wraparound, family voice and choice means that the youth and family tell us what they believe would be most helpful. And then the care coordinator ensures that the team is providing the family lots of options and choices to choose from. So let's look also at community-based. In wraparound, we are committed to making sure that families are together and that children and youth can go to their own home school, they can stay in their community with their friends, and can access the things that they love to do. And lastly, wraparound is a team-based process, meaning that it is not just about the care coordinator and the family, but the teams of relevant people that are in the family's lives. And that they're all coming together to develop and individualize a plan of care that the family can utilize. This means that no two plans of care will ever look alike because each should be individualized and be the best fit for a particular family. Next slide, Kim. So let's talk about building a strong wraparound house. While the 10 principles set up a good foundation for building a strong wraparound house, it isn't enough. We know that these principles need to be translated into clearly defined practice models for staff so that they can be demonstrated in their work with families. We need to continue to build upon this foundation and clearly identify a practice model that outlines all the expectations. Additionally, we need wraparound implementation standards, which are research-based and evidence-informed, that enable us to assess progress on wraparound implementation and practice quality standards, which are known to be associated with successful wraparound care coordination implementation at the organizational level. There needs to be continuous quality improvement, oversight, and management to ensure that wraparound is implemented with fidelity and can provide the support necessary to achieve positive outcomes for both families and systems. So another thing we would like to take a look at is the differences between care coordination for adults and care coordination for children, youth, and families. Care coordination for adults looks very different than care coordination in the children's system. On the adult side, care coordination is focused on adults who have met the criteria for serious mental illness. Unless the consumer agrees to have the family involved, the work is focused solely on the identified consumer. Children are not just little adults, and so it's essential that we have a different approach with youth and families. In a wraparound, a youth may or may not have a mental health diagnosis. They may have multi-system involvement or be exhibiting behaviors that put them at risk for out-of-home placements. High fidelity wraparound requires that there is a dedicated care coordinator who partners together with the youth and family and ensures the continuity of care throughout the planning and ongoing review process to facilitate the ebb and the flow of providers that will go in and out of the family's life. It's important to remember that families in wraparound do not want to be part of systems forever, and they want to be able to move out of services and participate in the things that are more aligned with their own unique culture and community. So let's take a look at the socio-ecological framework. So this idea is that when we have a young person who's referred for services, the way that our system works is that the young person gets referred, not the actual family. And so the referral typically is because something has happened with that identified youth. As part of wraparound, we need to understand the relationships that young people are a part of, their peers, their parenting, how the parents are parenting. All of the youth social connections are really, really important, as well as the institutions and organizations they go to every day, like school or work or places of worship. We need to understand that the communities families live in and the policies governing what we do, we need to put that all into the context of society. And I think probably there's been no greater example of this than what happened with COVID. During the pandemic, things shut down, and what we saw around country, good, bad, or indifferent, whatever it might be, there were different reactions and different approaches to how to manage that crisis. This is where the societal and policy component come in. And these things can really impact young people and their families in a very big way. So what happened with COVID is parents and their children were home together, trying to learn, trying to work in a shared space, trying to navigate their new roles and figure out how to make it all work. And it was really difficult for families. There was a lot of pressure for both the young person and the family. But we can't stop there. We have to consider the socio-ecologic framework in terms of how society impacts youth and families, the biases and the prejudice that are out there, how poverty or marginalization can impact a family. And that leads us to what we're going to talk about next, which are the social determinants of health. So we're going to show you a video first. So the social determinants of health are non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and the wider set of forces and systems shaping the daily conditions of life. So we're going to have you watch this for a moment, and then we'll talk about them a little more.
Hey, Dad, I wonder if we'll see anyone we know at the carnival today.
Daddy, that's my friend AJ and his dad.
Hi, Samantha. Are you going to the carnival too?
Yep, I can't wait.
Me neither.
Hey, AJ, look, that school is a lot bigger and nicer than ours.
Yeah, they probably don't even have to share rulers and markers in class like we do. And their playground looks brand new. A lot of things in this neighborhood look different from our neighborhood.
That's true, AJ. Some neighborhoods look different than others and have different resources too.
What are resources?
Resources are things like hospitals, schools, stores, parks, and restaurants. There are different types of resources in every neighborhood. Some communities have less resources than others, or resources that aren't as nice.
The types of resources in the places where we are born, live, learn, work, play, and worship affect both our quality of life and our health. We call these social determinants of health, and they can be grouped into 5 major categories. Economic stability means people are able to afford things like healthy food, healthcare, and safe housing. Employment or job programs, career counseling, and availability of childcare can help increase economic stability in communities. People with higher levels of education are more likely to be healthier and live longer. But some children live in places with poorly performing schools, and many families can't afford to send their children to college. Programs to help children and adolescents do well in school and help families pay for college can also help people be healthier in the long term. All people should have access to quality healthcare. Increasing health insurance coverage helps make sure more people get the healthcare services they need, like preventive care, including screenings and ongoing treatment for illnesses. Everyone should be able to live in a safe neighborhood where it is easy for them to make healthy choices. Safe and healthy neighborhoods have access to parks and safe sidewalks for walking and recreation, access to stores where healthy food is always affordable and available, and safe and reliable transportation. People's relationships and connections with family, friends, coworkers, and community members can have a major impact on their health and well-being. Programs and policies to help people have the social and community support they need are important for supporting health and well-being.
Yay, we're here. I'm glad the carnival is a resource we can enjoy.
Social determinants of health are connected and related to each other. Together, all of these things will help improve the overall health of people. By working together, we can help ensure everyone has access to the necessary resources and support they need to be as healthy as possible. Learn more, take action, make a difference. Visit cdc.gov/health equity to learn more.
So in Wraparound, we pay attention to these social determinants of health. And you'll see those that are listed in the colored blocks right around the word social determinants of health. And so again, these are those non-medical factors that influence health outcomes. So when you look at the wheel, you see things like gender equality and limited or no access to supports and services. So let's take a look at the gender and the lack of gender equality. When families experience this and have it pressing in up against them, it may result in lower wages, perhaps even some challenges related to employment, career ladders, or even abuse in the workplace. When we look at limited or no access to services and supports, when families are not able to access services in their time of need, increased illness may occur, and this may result in a decreased chance of the family reaching out for help when they need it again. Additionally, families may feel a sense of hopelessness and may be overwhelmed with the things that are going on and not think that things will change or get better over time. So if we're not paying attention to the impact that social determinants of health have on families, we won't be able to develop effective plans of care that adequately address the family's needs. So I love this visual here. Wraparound is actually a family-centered approach. And in Wraparound, we are very intentional about this because children and youth grow up in families. And so this means that we need to plan around not just the young person, but the entire family. So as you can see in this visual, other family members may also have significant needs. And we attend to these in Wraparound to be able to support the family holistically. If we zero in only on one branch, it leaves many needs left unmet, which will impact the entire family. When caregiver needs are actually supported, it increases the caregiver's confidence and capacity to care for their family despite the stressors that might be pressing in against them. And so I like to look at this in terms of also a cultural continuum. So at a systems level, we need to make sure that we are implementing services in a way that's culturally competent, and so that our agency and our organizations can work effectively in cross-cultural situations. In Wraparound, many families come from diverse backgrounds, experiences, and settings. And this means that we must demonstrate the awareness and integration of both the socioeconomic framework and the social determinants of health as it relates to the family that we're partnering with, as well as the family's belief systems and their traditions. So in Wraparound, our care coordinators take a relational stance of cultural humility when they're working with youth and families. They're curious about the family and demonstrate a willingness to listen to the family's story, which is foundational to building a plan of care that is unique to this particular family. Cultural humility really just requires an ongoing self-exploration and self-critique with the willingness to learn from others. It means entering into a relationship with a youth and family and not having all the answers or not being the expert and being okay with that as they're working with families. When these two things happen, what the family actually experiences is cultural dignity.
Thanks, Tony. That was great. In these virtual spaces and folks are at home, my dog, just as an aside, is snoring so loud right now. So I hope you don't hear it. But if you do, just know that that is what is happening. She's an old girl, she's 16. So, but now I want to talk to you about the phases of wraparound. There are 4 phases. I want to walk you through them, but I want to walk you through them in a way, pointing out what families have indicated are most helpful for them across the phases. And then we will talk about the care coordinator expectations and all of those things. But I think it's really important to hear that voice, and what families are saying that they need. And so phase 1 is engagement and team preparation. And I want you to remember that these are really young people and their families that are at the tippity top of that tiered care coordination pyramid. So young people with the most complex behavioral health needs and their families. And when they are referred for a wraparound, that means there's probably a lot of things that they've tried that haven't worked. And they've probably had a lot of people really wanting to focus on their child. And they want to know that this process is going to be about their whole family. So that tree that Tony talked about with all of those branches, they want to know that all of that is going to be attended to, and that their opinions around what has worked, what hasn't worked, how they got here, that this matters. Again, taking that relational stance with families. And because of everything that they've experienced to get to this wraparound space, we can't confuse any caution or hesitancy with apathy or resistance. They're just, they're worried. They don't know if this is going to make a difference for them. And they just want people to know that they love their children and they want what's best for them and their whole family. They know that there could be bumps along the way, but somebody's going to stand next to them and be with them as they take this journey, and that they're not going to be overwhelmed by too many people or too many services. I think there was a notion probably in the 80s about this idea of wrapping services around the family. No, that's not, we've evolved. We've moved on from that. What is that? I'm not a math person, but I think it's like 50 years, right? Or almost 50 years. Let's see, how old am I? We won't go there. But just knowing that it's not about wrapping every service that a system has around a family. It's too much. It's overwhelming. It's not going to be helpful. So just stop it. That's all I really have to say about that. Stop doing that. In phase 2 is the plan creation, and families say that they really want to feel and experience movement in a direction that gives them hope that things can be better. That is so important. And that they want to know that they have people in their lives that are going to focus on what they do well, what has worked, rather than what hasn't or what they can't do. And they want to know that this pain, this burden of what is happening or going on in their life right now is going to be shared and shouldered with someone who cares about them and, can sit with those worrisome details too. And they can take away some of that burden from them. They want to be respected, that their opinions are valued, and that any safety concerns are going to be addressed more than, by more than just a phone number, which in this day and age of 988 and mobile response and stabilization, I get that's a phone number. I do. It's a short one, but I get it. But that somebody is going to show up. Right. And so even in a best practice mobile response and stabilization service model, which I know we're not talking about that today, but I just want to point out that when families call in crisis, someone needs to respond. Because I need you all to think about this. When there's a crisis happening in your life with your family, if you reach out to the police, if you dial 911, if you call whomever it might be, in this day and age, if we call 988, right? Like, that takes a lot. Like, I have to call a lot of other people before that's going to happen. And then I want someone to attend to that, and someone that's going to show up and be helpful. You know, help should be helpful, but that is a whole other conversation, potentially. So in phase 3 and plan implementation, families also want to make sure that action is happening. There are some states that we partner with where this kind of paperwork and eligibility takes forever, and we need to get moving. Like, by the time they get in, which I know it's hard for systems to, figure this out. But when they get in as care coordinators, we need to make sure that we're moving and shaking, that this action is happening, and also understanding that whatever we put in place now may not be the best plan tomorrow. And that we're all going to come back together and that we're going to say, hey, is this working? What can we do different? Are we making progress? And then if that's not happening, that changes are being made. Please, 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 like, don't keep doing things that aren't working, and make sure that we're brainstorming, we're talking about other opportunities, and we're changing things up. And then in phase 4, the transition phase, we want to make sure ultimately that a family's needs and resources are balanced, that families are confident that they have the right skills to solve problems and manage conflict, that they feel a sense of independence, that they have realistic expectations for their family and the future, but that they know how to access those things that they need. Those things are available to them. And this renewed sense of hope, that there's this awareness of their own capability to brainstorm kind of new actions in response to challenges that could come up. But they're really feeling hopeful about their future because they're connected to support. When they hit bumps, they can reach out, they can have a chat, maybe with a peer parent partner, which is a great resource. If you don't have that in your state, you may want to advocate for it, though it's a lot more prolific now than it was back in the day of those grant funds. But just making sure that as we're transitioning out of wraparound, again, that needs and resources are balanced. And so I want to talk about a little bit about the care coordinator. And so I'm going to show you a quick snapshot of the care coordinator activities over the course of wraparound. And the average length of service is about 12 to 16 months. And so in this first phase, as you can see, there's a referral that's been made. We're meeting with the family. We're starting to build that relationship, right? We're understanding their life, where they've been, and where they want to go. That's called a family vision. We're also starting to identify any needs that they have, crisis and safety planning, building from their strengths. And all of this is going to happen in the first 30 days. I know that sounds like, whew, that's like a lot going on in 30 days. But let me tell you, some states have shorter timeframes than this. But again, this is so important because these are young people with really complex needs, and their families that are like, ooh, we need some help. And so we can't languish. We can't, sit back and relax. We got to hit it, get it, and go. And then in that next phase of wraparound, that plan creation, that this is a teaming process. And we're going to talk about that in just a second. But this is where we're setting the stage, we're establishing ground rules, we're sharing information that we've learned, we're facilitating action, and we're tracking progress. hugely important. And this first meeting, this first wraparound team meeting is roughly a couple of hours. It takes a minute when all these folks are coming together. And again, I'm going to talk to you about that teaming process in just a second. And then when we get to this plan implementation, this is phase 3, the care coordinator is sending out copies of plans of care so that people know their tasks and strategies that they've been assigned. They're responding to crisis, they're celebrating success. These meetings are happening every month. Every month, folks are coming together to check in, and we're changing the plans if it's not working. Please change those plans. Listen to the family when they say that things aren't going as they would like. And again, between 12 to 18 months, this wraparound team is meeting monthly. And then in the transition phase, we're compiling resources, we're making sure that the family's connected, we're sharing all of those successes, and then we're celebrating. This is a lot of work. These are a lot of folks that have been together for a long time, done a lot of work, and we want to celebrate that. And this is probably the last 60 to 90 days of the process. And then, hopefully families are launched and they're feeling hopeful and independent and all those things that we just talked about. So now I want to move on to this team role. Let me just say that everything in wraparound happens in a team. And by team, I mean, it is not the care coordinator and the family. It is all of those any service providers that might be on the plan of care, their friends, family, all of those informal supports. They're all coming together to create an individualized plan of care that's facilitated and managed by a dedicated care coordinator. Now, there's a lot of loaded words in there. Dedicated care coordinator means this is all that they do. They're not providing other services to the family. They're not also the therapist or the behavioral support or whatever. It's a dedicated care coordinator responsible for facilitation of this process and that creation of the plan of care with all of those folks that are involved with the family. That everyone on the team understands the family's life, they understand how they got here, and that they understand where the family wants to go, what they hope to achieve, and that they're coming together with not this automatic idea or notion of what the family needs. That we're really going to listen to each other, we're going to brainstorm, we're going to bring all of our creative ideas to this space, and we're going to collaborate with each other. We're going to volunteer our resources, and we're going to put forward our best expertise, which actually may not have anything to do with our specific job or the thing that we get paid to do. It could be that we have expertise in something else, or that we know someone, because remember, this is a relational process. It's all who you know, who can we help connect, and those things in this idea around collaboration. And again, that we're changing things if they're not working. We're bringing all of our ideas and options. We're collecting and sharing data based on around behavior change, any progress that's being made. And I also want to remind you that we're in this wraparound space because other things have not worked and needs are complex. We can't assume that things the family has tried in the past, or even things that they're currently involved in, should continue. We have to ask the question, is this helpful? Is this working? And if the family says not really, or or no, or well, I didn't have any other option, I don't know about other things, we don't just say great and write it down anyway. Those are gone, right? Those go, and we come up with new ideas. And sometimes those services and supports are working. And so then we want to pull it in. We do want to pull them to that team. But don't make that assumption that whatever a family is involved in when they're referred need to stay, that we as care coordinators need to remain neutral, even if they're provided by someone else in our organization, that we are bringing new ideas and we're discussing them as part of this team process. And also, I think sometimes Wraparound gets the reputation of being this strength-based thing, right? This fun stuff that happens on the side. No, that's not it either. We want to integrate those mandates, pull in information from any child serving agencies or other organizations that they may be involved in. And we want to build on existing relationships and supports that families come to us with. They all have them. We just have to find them. We have to ask about them. We have to care about what those answers are. And so it's not about the fluff and all of that. There are tough things going on. And again, I think Tony mentioned earlier about, no family wants to stay involved with systems. And so we're working to understand what's needed so that they can move on from that system, go play soccer or I don't know, chess or something, whatever it is that they're into, whatever it is that they want to do. And that's super, super important. Oh, I am so sorry. I went too far. Okay. Sorry, Tony.
All right. Thanks, Kim. I'd like to draw your attention to the quote that's on the screen. Pat Miles, a well-known and respected national consultant, fellow trainer, and good friend, describes the cultural shift that needs to happen, which is to move away from the image of rescuing children from their families to an image of family partnership and preservation. So in Wraparound, we intentionally partner with youth and families to preserve relationships within families and to preserve relationships within their communities. Often, as Kim said before, families may fail up the system. We saw that also when we looked at the social determinants of health, that families experience isolation, blame, sometimes even shame, and an intrinsic sense of hopelessness. So in Wraparound, we believe that hope is more than a feeling or an emotion. Hope is actually a thought process that we can infuse and teach children and youth and families, as well as team members, how to hope. The definition of hope is that the belief that your future will be better today and that you have the power to do so. The first half of that definition is simply optimism, which is really just a belief structure. Hope is an active process. And so when we're hopeful, we can do a lot of different things. First, we have to be able, as Charles Snyder says, there's 3 key elements to hope. The first is thinking in a goal-oriented way. The second is to be able to figure out ways to achieve that goal, including the ability to stay flexible and develop maybe some alternative plans, and this belief in ourselves that we can do this. So hopeful people don't just wish things into existence. Hope requires a person to take responsibility for their goals and take action to work toward the goal. Optimistic people see the glass half full, but hopeful people ask, how can they fill the glass full? So let's talk about what ties us together. Margaret Ginsburg wisely said that what ties us together is the ability to connect youth and families with hope. In Wraparound, we overlay hope theory onto the work that we do with youth and families. In Wraparound, the family's vision, which they define for themselves, is the goal. And then as a team, we develop strategies and brainstorm robust options that a family can prioritize and use. And then the team has this belief that we are capable to be able to achieve these goals. Hope is also a function of struggle. It requires us to acknowledge that things are difficult, but it also acknowledges that good can happen and good is possible. There are two prerequisites for hope. One is perseverance, and the other is tenacity. Individuals with the highest levels of hope have also had the most experiences with failure. So in Wraparound, one of the principles of unconditional care says that we'll be there no matter what. And so this tenet works with us. And so we need to ask ourselves always, again, what are some of the social determinants of health that might be pressing in against a family? What are the other things that we need to pay attention to that may be impacting their lives? There's actually some new research from the Tufts School of Medicine that indicates that when we can teach hope to families and youth, we can reduce the effects of adverse childhood experiences by providing positive childhood experiences. And so I want to talk a little bit about how partnership has evolved over time. And so the first published definition of the term system of care was in 1986, actually. I think the slide says 1992. But in it, it talks about a comprehensive spectrum of mental health and other necessary services, which are organized into a coordinated network to meet the multiple needs and changing needs of children and their families. This updated definition that you'll see below talks about a community-based set of services and supports for youth at risk for mental health or other challenges and their family that is organized into a coordinated network, and that they build meaningful partnerships with youth and families and address their cultural and linguistic needs to help them to be able to function better in their home, in their schools, and in their community, and once they leave services throughout the rest of their lives. So family professional partnerships, it's a journey. It's never really a destination. It really is founded on how well we build relationships with one another. And it involves honest dialogue and two-way communication. So in Wraparound, team members need to be committed to being open and honest with each other and agree to work through conflict as it arises. Additionally, we need to pay attention to how power is shared. Just the nature of being employed as a provider of services creates a power imbalances when we partner with youth and families receiving services. When developing partnerships in Wraparound, we pay attention to and provide opportunities to share power. This happens when families provide their own perspective and preferences as they prioritize the strategies that they think are best for their families, and they're providing their voice in all of the decision-making processes. The last tenet around this idea of building family professional partnerships is attention to how responsibilities in planning and decision-making are distributed. In Wraparound, we make every conscious effort to task a strategy to every single team member on the Wraparound team. The responsibility should never fall on the youth and family alone. And as Kim has mentioned before, part of Wraparound is to let families or have the opportunity to have a team share and bear some of the burden of what they're experiencing. So this quote, I think, is really powerful. It says, equal partners, when we talk about family professional partnerships, does not mean that parents and professionals assume each other's roles, but rather that they respect each other's roles and contributions. While professionals bring technical expertise and knowledge into the relationship, parents offer the most intimate knowledge of their child and family, and often special skills that they bring to the table.
And so in systems where they're trying to install, a robust statewide approach around wraparound, outcomes are important. And as Tony mentioned earlier, wraparound as a system intervention means that systems have to stay checked in. And when we're talking about systems, we're talking about states, we're talking about Medicaid, we're talking about departments of behavioral health, that we are purposefully and routinely monitoring these things, that we hope we see. So on this slide, you'll see a whole lot of bullets. States choose various things depending on, what their data show and they're reacting to. But I want to highlight just a couple of things. That the system needs to be rebalanced with more diversion and financing going to prevention and home and community-based options than deepened residential congregate care settings. And also that families are reporting that services and supports that they need are easy to access, that when they access them, they're like, "Ooh, that was actually really helpful," and that they're better off because of the services and supports that they participated in. Super important. And I also want to talk to you about a little bit of data. We talked earlier about a 2017 systematic review of wraparound. And honestly, I think wraparound has more data and research behind it than a lot of other evidence-based practices. But what we know is that there's better functioning, mental health outcomes, reduced costs, reduced residential placements, and increased rates of permanency. And these results were duplicated and enhanced again in 2021 when we looked across the country, because again, the studies are demonstrating more positive effects for wraparound than compared to treatment as usual. And I would also say that, it's what we're starting to see emerge are also indications that wraparound works well with people of color and populations that are marginalized, because again, it's that person-centered, family-centered approach of kind of that do whatever it takes in a Medicaid world, but meeting families where they are, and making sure that we're checking in along the way, that things are helpful and so on. And also I'm sorry, I didn't change the slide when I was talking about that. I was just so excited to talk about it that I forgot. But local evaluations around wraparound showed very similar outcomes, that decreases in out-of-home treatment, hospital admissions, decreases in long stays in foster care, Medicaid expenses, emergency room visits, lengths of stay in residential systems, and so on. There is a caveat to all of this, though. If you haven't realized that yet, that I'm going to tell you about them, that wraparound has to be done well. So when I mentioned earlier that wraparound light isn't a thing, not a thing. Wraparound needs to be delivered with full fidelity to the model, and it needs to be reserved for high needs populations. Otherwise, it's just not going to be real effective, and families are going to push back a little bit because it's a lot, right? When you don't need that level of care. This is just some basics around what is needed to assure good outcomes of wraparound. So that system component is really important. Those financing structures, be it Medicaid, be it waivers, be it sometimes still grant funds, block grant dollars and so on, that we're really clearly defining the population, that we have low staffing ratios, and that workforce development support is available. Very, very important. And these implementation and quality standards can be accessed. There's a link at the bottom of the slide. And I just want to again emphasize that if we want families to actually experience what's outlined here, where there's an identification of a complex need, they're referred, they're eligible, they're walking through these phases of wraparound, that this does not sit with the families alone. The system has to do a lot of work. They have to have a system design, policies, regulations, procedures, workforce development, rates, and so on that support this experience in wraparound. And likewise, providers need to have quality staffing. They need to collect data. They need to have policies and procedures, again, inside their organization. And that we're continually asking ourselves, are we being helpful? And did things get better for young people and their families?
So I had a little trouble unmuting that time. I'm not really sure what the heck happened. But I wanted to share something that Dr. Chad Hellman shares from the Oklahoma Hope Research Center that says hope can actually be measured. And so one of the things that I think is really important is that there's robust science with over 2,000 published articles that tells us that hope is the single best predictor of well-being across the lifespan. That means improved physical health as well as social and psychological well-being. For youth, this means increased school attendance, grade point averages, graduation rates, and increased rates in going to college. So in Wraparound, we partner together with families, and we also help to teach hope to make sure that families don't have to walk the journey alone, to recognize that their future can be better than their past. Youth and families deserve to have other people walk alongside them so that they don't have to go through the tough times alone anymore. And as wraparound providers, we are there to inspire, support, and intentionally nurture and teach families how to hope again, to restore the belief that youth and families have the power within themselves to make the changes necessary to reach their goals. All youth and families need a little help sometimes, a little hope, and somebody who believes in them until they can believe in themselves. Thank you.
Thank you. So here is our contact information. Again, if there are questions or if you wanted to reach out, and some references, some resources for you all. So I'm gonna stop sharing so that I can see everyone and see if we have any questions in the chat. I could not see any of that while we were presenting.
It's okay, I was keeping track.
Okay, good. Thank you, Bevan.
Thank you so much, Kim and Tony. I hope this was fabulous information, and your work is incredible, and it's really inspiring to see a model that is this robust as an example of the ways in which systems can really be person-centered, really center the family, really be driven by the family. We've had some really good questions in chat. We also got a few questions in registration, so we have 10 minutes, and I'll try to kind of get to as many of those as possible. We had a great question come in just now from Lee that I was wondering about as well, which is, can you share any examples in states or any local jurisdictions that are kind of doing wraparound well at that kind of system level?
Mm-hmm. Well, I think that, states are still trying to figure some of it out. I think that there are states that have good pockets of things. I also think it's very dependent on financing structures and the implementation context. And so I would say that the states that are doing the best are those that have those dedicated organizations, meaning the care management entities, the care coordination organizations that are dedicated to care coordination alone, because then they are pushed out, they have to connect with other providers and other organizations, community-based organizations, and so on. And that's their sole responsibility. They don't have any connection to or preference for, certain providers over others. I would also say states that have robust support for their workforce, meaning that they've taken the time to concretely define the expectations and what wraparound is, that they've written that into their policies, their expectations. And then there's accountability mechanisms that they're celebrating wraparound done well. And those are the states that we see that are most successful in this work.
Fabulous. Yeah, thank you. And what you're saying really speaks to the complexity of this and how to really realize the value. It takes a lot of different factors and things that we work for best practice and systems in general.
Absolutely.
Can you share a bit, I guess kind of on the flip side of that, one of the things that, and we got some good kind of critical comments in chat around just like, there's the ideal that you shared around kind of within the first 30 days, all the paperwork is done and the meeting happens and there's a good plan. And then, that contrast that with the reality. So like Amy indicated that, they've got examples of families that are in crisis that spend like months just in the paperwork side of things. And in situations like that, when the implementation really falls apart, it can be so easy for families to kind of give up. And even worse, it can kind of like reinforce mistrust in the system working and sort of deepen that distrust. So can you speak to, you highlighted so much already the critical importance of these implementation factors, but can you speak a bit more to just the ways in which some of those implementation barriers can be overcome to really get to this model bearing fruit?
Yeah, absolutely. I know, Tony, you probably have thoughts around this too. And I think for us, both Tony and I have done the work and we've been in it. And so we understand the pressures. And I think I don't know, Tony, you jump in as well, but the climate and culture of the organization that it sits, I think is so critical to what is emphasized, because what gets emphasized, what gets tracked is what gets done. And so as organizations, if we're emphasizing the relational stance, if we're, really honoring this idea of building hope, I think it goes a long way in how we get through the paperwork and what's kind of seen as our job. And it really changes the perspective. I don't know, Tony, what do you think around what Bevan is asking?
Yeah, I too think what you shared, Kim, is really true. I also think, for me, experiencing wraparound, then working in wraparound, the things that really resonated with me as a parent, and then what I saw in systems, was really focusing on the workforce, celebrating their successes. Really great family stories were highlighted in team meetings and those kinds of things. There were lots of partnerships that were happening with youth and families. If people were behind with their documentation, teams would take over and take calls for families to try to make that work. And that really happened in the care management organization. So they really supported each of their teams well, and they created a healthy kind of competition to do the work and do the work well. And I think that that was a good motivating thing for New Jersey, actually, when they were first implementing wraparound.
Yeah, thanks for that, Tony, and for highlighting the importance of the sort of peer practice components of wraparound and the way that is infused throughout the model. Let's see. Can you say a bit, half of the folks on here are government employees. So, and we did have a question in registration around, what's the role of the state at the state level in sort of monitoring and ensuring that wraparound happens? Can you point to any best practice there?
Absolutely. I think that outer context, when we, point back to implementation science, the system is that outer context. I think that that is really important. And as I mentioned, later on, as we were ending the presentation, that systems have to stay checked in. Wraparound as a system transformation model means that we have to pay attention to families' pathways to care. And that simply means their process to and through the system, and how does systems and states oversee that work to make sure that they're matching the intensity and urgency of response to the intensity and urgency of need of the family. So they've got to set clear expectations around the practice. They have to be nimble enough to let staff do the work of building relationships with families. And really tangibly, that means let's pay for some of those engagement opportunities, right? Where a plan of care has not been developed yet, because we're still building that relationship, we're building a team and so on. So let's reinforce that work. And so aligning the expectations at the state with what we know works at the practice level, because again, it's not just this fluff and all of these things. It matters. Like these things have been shown over and over again to be the most effective pieces associated with wraparound. And so I would just say, I know it's hard to align CMS and, Centers for Medicaid and Medicare Studies and all the federal regulations with the state regulations and all of these things. But really being mindful of how can we be as flexible as possible to recognize that what families need may not sit with a billing code or a face-to-face interaction, that it's probably something else. And how do we honor that?
Wonderful. Thank you. Thank you for that. Well, this is great. Kim and Tony, I think, you've gotten lots of great reactions in chat. This is rich and important information. I noticed that Ryan shared information about connecting with other wraparound folks around the country. I think that's awesome. Maybe as a parting words, Kim and Tony, are there any particular resources or work that your center does that you might want to let folks know about if they're interested in encouraging their states to strengthen or adopt wraparound principles? What are some resources to leave folks with?
Tony, I don't know what you have, but just real quick, our website, which I think is also on the slides, that we work across levels in the system. So at the state and provider and frontline workforce development levels. And those are good resources. I don't know, Tony, what do you want to leave them with? Uh-oh, that mute button.
Yeah, I would agree. I'd point to the website. The other thing that I would just like to highlight is the role of peer parent support for the few people that were on there that I saw do peer parent support, and how well that can be done in conjunction with wraparound. Peer parent support is also a critical and essential service, but it doesn't have to be done in partnership with wraparound. It can be done as a collaborative effort alongside of it. And so we also have, I'm going to put in a plug for our Pearls program and certificate process. And I think that's where I'll leave it.
Fabulous. All right, we've got some resources, we got some folks in chat, and we have a poll. Please, before you leave, let us know what you think of this webinar. We use the information and the feedback to continuously improve our webinars. We stay tuned for another webinar along this same lines in the next couple of months. We'll be announcing that. And in the meantime, I hope everyone has a great rest of your day. And we so appreciate you being here with us, and so appreciate Kim and Tony for sharing their wisdom today. Take care, all.
Thank you.